Bom, now we can go on. Então, bem-vindos a quem nos assiste no YouTube do IBDPAC. É muito bom estar aqui conversando com vocês hoje. E hoje nós temos um convidado especial. É uma honra para o IBDPAC, né, receber o nosso convidado de hoje. Meu nome é Cíntia, eu sou uma das diretoras do IBDPAC. Então, nosso webinar desse mês tem a honra de receber o professor Victor Montori, que é o nosso convidado especial. E antes de começar, eu vou só dar alguns esclarecimentos, depois eu vou apresentar o professor Victor e aí ele vai iniciar a apresentação dele. Então, o primeiro aviso é que se a gente tiver algum problema de conexão, a gente teve agora em alguns momentos atrás, se o YouTube cair, se acontecer algum problema de conexão, a gente pede que vocês aguardem um pouquinho, porque tem várias pessoas tentando resolver e ajudar aí no apoio dessa transmissão. Então, caso o vídeo caia, vocês aguardem um pouco, porque isso já aconteceu em outras transmissões, infelizmente, então a gente já dá esse aviso antes da gente começar. A apresentação do professor Victor vai ser em inglês, mas com duração, né, de cerca de 30 minutos, mas a temática que a gente divulgou nas nossas redes sociais é sobre o tema da tomada de decisão compartilhada, né, que o IBDPAC sempre está trazendo esse tema para discussão nas nossas conversas, nas nossas aulas, mas depois disso, ela vai ser em inglês, mas depois a gente vai colocar uma legenda em português para atingir o maior número de pessoas possível, para a gente continuar divulgando essa temática da tomada de decisão compartilhada. As perguntas, depois da apresentação do professor Victor Montori, a gente vai ter um tempinho curto para perguntas, então quem tiver perguntas pode colocar no chat do YouTube, e aí a gente, na medida do tempo, vai tentar trazer as perguntas para o professor Victor, ok? Então, Professor Victor, welcome to IBDPAC webinar. It's a pleasure stay here with you. Yeah, and I'm going to introduce you, and after, before that, you can start, okay? Professor Victor is professor of medicine at Mayo Clinic. He's a recognized expert in evidence-based medicine, sharing decision-making, and minimal and disruptive medicine. He works to advance patient-centered care, specifically for patients with diabetes. He is the author of the book, Why We Revolt, and is leading a movement, Patient Revolution, for careful and kind care for all. Thank you for your accepting, and we can start now, okay?
Thank you very much, Cynthia, for the introduction, and I'm very happy to be here. We'll be talking about shared decision-making. This slide has my email address and my Twitter handle, and you're welcome to send me questions or comments after the presentation in either of those to either of those addresses, and I'll be happy to respond if there's no time for your question during the session today with you. This presentation is about shared decision-making. I do not have any financial relationship to disclose. All the work that I'm going to be describing here that we have conducted at the CARE unit, which is the Knowledge and Evaluation Research Unit at Mayo Clinic. All my income comes from my work as a physician at the Mayo Clinic. And we do not, at the CARE unit, we do not receive funding from any for-profit corporation. In 2017, I published this book, Why We Revolt, founded the organization, The Patient Revolution. I chair the board of that organization. The income from the book goes to the organization, and as an official of the organization, or in any other capacity, I do not receive any payment or draw any funds from the Patient Revolution. This conversation, although is about shared decision-making, it must start where shared decision-making finds its goal, which is in care. And during the pandemic, I think care has been at the forefront of people's minds and people's imagination, where we discovered that care was happening at home, was happening in long-term care facilities, was happening in the hospital, in clinics, but also there was a big economy of people that were called essential workers that were also caring for us in a number of other capacities. Care became the focal point of our survivorship in the pandemic. But care is often not fully discussed. So I want to spend a few minutes discussing what care is supposed to be. And so care is a practice and a disposition. It involves noticing and responding. Noticing what is the problematic situation of a person and deciding to respond to that situation. Noticing requires paying attention, being present at the moment, understanding that situation in high definition, in detail, not only in terms of what is needed, but also what might be assets or strengths that the person in need, which we'll be calling the patient, brings to our attention. And the response is actually what creates the decision to respond, is what creates the possibility that we can improve on that situation, and that gives people hope. It also is the space that says, well, let's invent some action that we can bring forward here to advance that situation. So caring is noticing and responding. Caring is also caregiving and care receiving. Giving care, it means working with the person, not just to the person, but with the person that it needs our care, with competence and compassion. Care is never finished until we hear from the person that we are caring for and with, to know that our care is pertinent, our response has been adequate, and is considered desirable by the person that's receiving. That's what care is about, a practice and a disposition, noticing and responding, giving and receiving. Now, when we think about care, we think about patients, and here is Maria Luisa, and you can see she's at her home, and she has a lot of pills in front of her. These treatments are the result of clinicians understanding Maria Luisa's biology, responding to the fact that she may have diabetes or hypertension or depression or osteoporosis, and responding to the biological mechanism of her condition with a drug or treatment. But that response cares for people with that same biology, cares for people like Maria Luisa, but that is not our job. Our job is to care for Maria Luisa, not for people like her. And that requires us that we get to understand what is her biology and what is wrong with it, of course, but also what is her biography? Where is she coming from? What are her goals and priorities going forward? What is the context of her life now, and how does her life now affect the way her symptoms manifest, or the way the treatments are acceptable and can be made to work, and how side effects are going to be interpreted, and whether the treatment can be taken for long enough to have the intended effects. Without paying attention to this biography, our treatments will simply be generically responding to the common biology of people, and that's not very caring. To be able to capture that biology and biography, to notice that and respond to it, it is important that we have conditions for care. And the key condition for care is the unhurried conversation. I'm not talking about the long discussion, but the unhurried conversation, which I think is the most important innovation in modern healthcare, because it's the space and the time in which patients and clinicians can communicate and interact, to notice and characterize the problematic human situation of the patient, again, in high definition, and to co-create, work together to co-create a resolution to that situation that is sensible and advances the patient's situation forward. That co-creation, that developing of a common understanding of the problematic situation and then working to create a solution to it, is what we call shared decision-making. So shared decision-making is a method of care. a conversation in which patients and clinicians work out what to do, co-creating care that makes intellectual, practical, and emotional sense. This QR code at the bottom of your screen links to a paper that describes some of the content of this presentation, and you can use it as a handout at the end of the presentation to remember what we discussed today. And it describes the notion of shared decision-making as a method of care. Now, shared decision-making is not a way to empower patients. It's not a way to involve patients in care. It's not a way to inform patients. These are, of course, things that may happen as a consequence of working in this way, of having this unhurried conversation. But that is not the goal of shared decision-making. Neither is to fix healthcare waste or healthcare overuse, or to simply document patient preferences, or to distribute shared decision-making tools to patients so that patients can think through the issues on their own, or to delegate the decisions to patients after they hear what we recommend. It's up to you, it's your decision. None of these things are shared decision-making. So again, shared decision-making is a conversation in which patients and clinicians work together to uncover, discover, clarify what is the real problem that we need to address, discover together what could be done to address it, and then create a plan of care that responds well to that situation. And for chronic conditions, this process is an iterative process, it's an ongoing process. It's a process of refinement, of trial and error until we get it right. There are some tools that can help to both uncover or characterize the problematic situation and figure out what to do about it. The first of those tools is the statin choice. It's the first one we developed back in 2004, almost 10 years ago. You can once again use the QR code on the top right of your screen to go to the website of our unit, where we have all these tools available, all of them for free to use in clinical practice. The statin choice decision aid is a tool designed to show the risk, the 10-year atherosclerotic cardiovascular risk of patients on the left, using state-of-the-art method of description that actually shows, in green here, the people over the next 10 years that will not have a heart problem, and the people like this patient that will have a heart problem in the next 10 years. And then we can use this to describe to the patient that we do not know. We have no way of knowing if they will be one of these green ones or one of these yellow ones. Now, if all of these patients were to take a cholesterol pill every day for the next 10 years, what will happen? Well, at the end of 10 years, the 79 people that were not destined to have a heart problem would have taken a pill every day, but their situation would have been unchanged. For the 21 people that destined to have a heart attack, 16 will still have their heart problem despite taking the medication regularly. And 5 in light blue here will avoid the heart attack that they're destined to have because they took the medicine regularly. Once again, we disclose to the patient that we have no way of knowing if they're one of the green ones, one of the blue ones, or one of the yellow ones. And with this information, the patient and the clinician now can discuss whether that size of benefit is worth taking a pill every day for 10 years. This is superior to what we normally do, which is to tell the patients that their LDL cholesterol concentration in their blood exceeds 140 or 110 or 70 milligrams per deciliter, and that therefore guidelines recommend that we start a cholesterol medicine and they should be taking their cholesterol medicine every day, and so forth. A decision that does not open or recognize or make transparent that this is a value-laden decision in which people get to choose how they would like to live their life and face the risks, like in this case, the risk of cardiovascular disease and other preventive approaches. The next tool we developed is slightly different. And I think by showing you these tools, I want to show you different ways of supporting shared decision-making. So this one is to choose a diabetes medication in a patient who is not getting good sugar control on metformin. And this starts by asking patients which aspect of their next diabetes medication would you like to discuss next. For patients with type 2 diabetes, it is common that patients would like to start discussing the effect on their weight. There might be a couple of medicines here that will help them lose weight. A patient might be interested in those. Then you ask them, well, what aspect of those two medicines would you like to discuss next? They may want to know how you take them. This is a pill, this is an injectable. They may prefer to take the pill. Then you ask them, well, what else would you like to learn about this pill? How much will it cost me? And at that point, they may discover that it's actually quite expensive, and they might be interested in considering alternatives that may be less expensive and also are pills. So in this one, yes, the outcome is that there will be a selection of an agent, but the most important outcome is to listen and understand the reasons that motivate that choice as the patient and the clinician work together to figure out what to do. Now, shared decision-making is not just about tools, but it's also about creating a context in which it can be used. And so on the left is a picture of an office in which everything in that office indicates it is for shared decision-making. Not only are there very few distractions in the office separated from where the exam is, but the table is a semicircular table. The chairs are arranged around it with no hierarchy, indicating that the patient and the clinician will be working shoulder to shoulder, side by side, with the same access to the medical information to decide what to do together. No disruptions or interruptions allowed. And it also speaks to the nature of the relationships that one would want to have, relationships that in this picture are exemplified by having the eye level be at the same level and person and clinician really working with their body expressions, with the nonverbal expressions, clearly working in collaboration. What is the result of all these approaches to advance shared decision-making? These are summarized, 20 years of research summarized here in 4 lines. So the first one is that patients and clinicians are more satisfied with their clinical encounters when they are actually actively involved in noticing and responding, when they are involved in this shared decision-making approach. In patients who have less educational level, lower educational level, the existence of more support during the clinical encounter helps them the most, helps them to a great extent than patients that perhaps have access to this information and can come prepared for the consultation. So shared decision-making can produce similar outcomes in patients who otherwise would get care directed at a lower socioeconomic status. Despite all our efforts, the shared decision-making interventions have not had a consistent beneficial effect on health outcomes, on adherence to therapy, or on the cost of care. And within encounters that are about 20 minutes plus in length, the time used for shared decision-making is not different than the time used for usual care. Sometimes when we've tested this in randomized trials, in the usual care arm, patients and clinicians are usually engaged in discussions that are not going to contribute to making decisions. For instance, when clinicians explain the mechanism of the disease or the mechanism of action of drugs, perhaps with an effort to demonstrate their expertise, but in no way enhancing or facilitating the patient participation in that conversation. Now, there are 4 different kinds of shared decision-making that can take place, and they can be identified by considering what is the problem in care that we're addressing here, what should we be talking about together, and what form of shared decision-making should we use? And this is based on the work of my colleague, Ian Hargreaves. The QR code at the bottom of your screen takes you to his seminal paper from 2019, where he proposed these 4 kinds of shared decision-making and called them purposeful SDM. So let's explore these 4 forms of shared decision-making. So if the problem of care is uncertain outcomes with different approaches, what we should be talking about is what are those outcomes with those approaches and how they compare to each other. And for that purpose, we will use a weighting form of shared decision-making, which we will consider the different effects, favorable and unfavorable, pros and cons of the available alternatives, consider those pros and cons versus what we prefer to experience, and then decide together which of those is most favorable. This is the most typically described form of shared decision-making, but there are three more. If what the problem in care is a conflict, what we really should be talking about is the different positions that we've taken. Maybe the position of the clinician and the patient might be different, or the position of the patient with themselves, or the position of the patient with the position of a family member. There might be conflicts. And here, with the form of shared decision-making that might be most helpful is a negotiation, finding middle ground, arriving at a compromise. So an example of this situation might be where you might be interested as a clinician to give a patient a COVID vaccine, but the patient has heard that these COVID vaccines are problematic and may prefer to avoid it. Now we have a conflicting situation. Yes, as a clinician, you can educate the patient about the pros and cons of the vaccine, but that may not fully address the fact that the patient is now very opposed to this form of intervention. What then needs to happen is some sort of a negotiation and arriving at some compromise that still keeps the patient protected, while at the same time acknowledging that we have positions that are in conflict. Another form of shared decision making. If the problem of care is a troubled or confused situation, we are not clear what to do. What we need to be talking about is what are the elements of that situation, what is happening to whom and in what way. And the mode there of working together is problem solving. A patient who is in the hospital after treatment and needs to go home cannot simply just leave the hospital and go home without paying attention to whether the home is ready and people at home, their family is ready to receive the patient coming from the hospital. Figuring out what's needed to make that situation better, to make the family and the home better set up to receive the person who still has some recovery to do after the hospitalization, and decide what day the patient should leave, where all of those things will be sort of in place, is a form of problem solving decision making. And finally, when the problem is an existential fracture, an existential transition, where the main issue that we should be talking about is the sense of meaning and identity, the form of shared decision-making we should be using is one designed to develop insight. This is most common in patients at the end of life who are looking at the possibility of dying soon. And at that point, there might be some issues of pros and cons, there might be issues of conflict and problem solving, but the main thing is finding ways of allowing the patient to write the last page of the book of their life with their own handwriting in a way that makes sense of what is obviously a tragic circumstance. We have thought that shared decision-making was very rare in practice, but very recently, investigators from the Netherlands looked at video recording encounters from our research group here at Mayo Clinic and found that in encounters, not just at Mayo Clinic, but across the United States, in 100 encounters of patients with diabetes, they were able to find evidence of shared decision-making of one of these kinds in 86 of these 100 encounters, so much more common than we used to believe when we only were looking at one kind of shared decision-making. And you can see that while in the majority of encounters, there was only one form of shared decision-making used, and the most common form was the problem-solving form, when there will be encounters in which up to 6 different forms of shared decision-making were used. This is what this graph shows, and how when encounters had multiple forms of shared decision-making, clinicians and patients changed from one form to the other until obviously they found one that worked. So what is that purpose of shared decision-making? What is it that happens when shared decision-making works? What happens is care fits. And so my colleague Marlene Kunneman and colleagues, international colleagues, published a couple of years ago the Making Care Fit Manifesto. And in this manifesto, they announced that the goal was that patients and clinicians must collaborate in designing care plans that maximally respond to each patient's unique situation and priorities, while minimally disrupting their lives and their loves. That idea of making care fit gives reason for us to engage in shared decision-making to achieve care that fits. This has prompted a number of projects looking at developing shared decision-making science. Our research group is working on developing new measures of shared decision-making and to capture the frequency and nature of unhurried conversations. We are developing new methods to study clinical encounters and using new forms of shared decision-making tools we're calling agenda cards. We're looking at new targets to measure outcomes in the spirit of the Making Care Fit manifesto. And we're dealing with a bigger problem as we go forward, which is the problem of industrialized healthcare. In the next bit of this presentation, a final bit of this presentation, I will expand on this notion of industrialized healthcare. But at this point, I want to invite everybody to the Care That Fits conference that will happen in Rochester, Minnesota, between September 13 and September 15 of this year. That QR code on your screen will take you to the website where you can find out more about this very small academic conference focused on making care fit. Now, what is this problem of industrialized healthcare? And that is that as healthcare becomes more focused on giving access to people than processing people fast, we are obligated to move quickly through it. And as a result, healthcare is devoid of care and becomes unsustainable. That means that patients with chronic conditions are asked to do more, and such that 40% of patients are reporting an unsustainable burden of treatment as they try to implement their care. When they come to the visit, we spend 40% of the visit on the computer screen documenting care instead of caring. And when we ask patients, why are you here? We interrupt them within 11 seconds of their statement. And without able to make connections with patients and fulfill the promise that they made themselves to do healthcare, to care for people, 40% of working clinicians are expressing their intent to leave the practice, in part because of burnout. So what we have really is this industrialized healthcare, this conveyor belt of processing people. And the way out of that, as I mentioned before, is to create conditions for care that will make sure patients are not a blur, that our care is not generic and burdensome, or sometimes even cruel. For inspiration, I use this sculpture from Rodin, which in order to create these two hands, it's called the cathedral. The hands make the walls of the cathedral. The space between the hands is the sacred space in which things happen within the cathedral. And to work with this piece of marble to create that space, he had to remove everything that was in the way of these two hands, which, by the way, are two hands of two different people, for these two hands to come together and touch. This is a picture I took at the Rodin Museum in Paris, and I did something nasty, a little mischievous, which is I put my cell phone between those hands and took a picture from the inside, just to highlight the importance of making sure that we have the right conditions for care in order for shared decision-making to happen. And this requires us to pay attention to organizations and leaders that we need to make sure put care as the core purpose of healthcare, that work to improve the well-being and competence of clinicians, that enable collaboration and team-based care for mutual care, that ensure that any technologies and innovations that are brought in are actually designed to support care. There is good evidence, and this is a graph of 4 different aspects of those conditions of care. Clinicians feeling valued, having control of their work conditions, being able to work with teams and in environments that are not hurried or chaotic. And you can see that when those conditions are favorable, the rate of burnout is in the order of 20 to 30%, compared to the rate of burnout of close to 80% when those conditions are unsafe. This is why we are working towards a patient revolution for careful and kind care, to change those conditions for care. And to do that, we need to learn to notice the pathologies of care, make care the core purpose of healthcare, moving from hurry to elegance, from blur to high definition, from cruelty to responsiveness, from burden to minimally disruptive care, and respond with radical change in our culture and strategy. There is some evidence of progress. This is a picture from a TV show called The Resident. During season 6 of that TV show, the CEO of the hospital had a copy of my book on her desk during the whole season. Unfortunately, it is not a real CEO, but I think it's already sign of progress. Real progress will come when care stops being the means by which organizations operate to become their core purpose. When we invert the accountability and not have patients and clinicians accountable for developing value, but rather clinicians and patients can hold the administration, the bureaucracy, the institutions accountable for creating conditions for shared decision-making and care. We need to eradicate cruelty from healthcare, and we need to promote unhurried conversations. To finish, I would offer here some key take-home points. Shared decision-making is a method of care. Shared decision-making is not for getting people to agree with recommended care. Shared decision-making is for co-creating care to advance this patient's situation, not a situation of patients like this. The best shared decision-making method will depend on the type of situation and the role or purpose of shared decision-making in that situation. And to enable shared decision-making, it is necessary to value shared decision-making as part of care and to foster the conditions that are favorable to care. To do that, we need a healthcare system that is based on solidarity and not greed, on integrity and not rules and regulations, on elegance and not simply the efficient processing of patients, that is not care for patients like this, but for this patient, that is minimally disruptive of patients' lives, and that is based particularly for patients with chronic conditions on not on transactional interactions, but on relationships, which oftentimes are relationships of love. If we are able to do all this, and for this we're working towards a global movement for care within the patient revolution, we hope we can achieve careful and kind care for all. With this, I would like to stop and thank you for your attention, and I welcome your questions. Thank you very much. I think you're muted, Cindy. Cynthia, you're muted.
Okay. Oops. Thank you, Professor Victor Montori, for your explanation. It's a pleasure. Now I'm going to read some questions that we have, okay? You hear me?
Yes.
Okay. Let me see. How can we start at sharing decision-making in intensive care unit with sedate patients?
Obviously, if the patient is not able to participate, it is going to be difficult to have shared decision-making with this patient. There might be some ways in which the patient's perspective can be brought into that discussion. Efforts might include documentation of patients' goals and wishes before the patient was sedated. There might be photographs and stories about the patient's previous life before coming to the intensive care unit that will help clinicians understand how this patient liked to live and what was going on in their life before they became critically ill. And of course, doing shared decision-making with the family or the family representative who is there to advocate and to support their loved one while they are very sick. So there are multiple ways of doing shared decision-making, and the fact that the patient is intubated and sedated is not a reason to act paternalistically and decide on their behalf.
Yes, thank you. And one more. In Brazil, the patient is not invited to participate in our culture, and the patient only receives information and must follow it. How to improve patient participation and show that this is important to them?
Well, I think it is patients behave the way they behave because that's what we have taught them. We have told them that this is the expected behavior. And we do that teaching, for instance, by punishing the patients who ask questions, who have statements to say. We label those patients as difficult patients, or we signal to them that we are in a hurry. We need to keep moving. And so patients learn to simply listen and then decide, without the help of the clinician, when they go home, decide whether or not to do the treatment. So for clinician, there's a strong argument for making sure that the patient and clinician make the decision together. And to do that, the clinician has to come from their from their semi-God place, and they have to make themselves psychologically smaller and have ways of, over time, develop relationship with their patients so that they can be seen as a partner in care, not as the owner of truth, and that making yourself smaller can occur without giving up on expertise, without giving up on your training. Yes, you come in with training about the disease and other things, and you're expert on that. But the patient is an expert on their body, is an expert on their context, is an expert on their relationship, is an expert on their goals and priorities. And so we need these experts to meet us as equals. I know culturally that's not the case. So we need to work, and the most of the effort has to be made here, not how do we get the patients to rise up to the level of the clinician, but how does the clinician can come and make the communication and the connection with the patient as equals. That's a lot of work in an environment perhaps like Brazil, where clinicians have for many, many years developed the idea that because they are doctors, they are superior to the patient. Giving patients opportunity to have the language to participate is one of the reasons why these shared decision-making tools might be helpful. So developing those that are appropriate for the context of Brazil might be something that could be tried. And then the last thing is, while it may seem like the difficult part is to get patients to participate, I would put forward that there is another problem, which is that the clinicians don't participate. And what they don't participate is in the problem of the patient. So how might clinicians get to fully understand the problem of the patient if they maintain a distance to the patient, if they don't listen to the patient, if they don't invite the patient to tell them what is going on with real empathic curiosity? I don't think that happens. And as a result, the patients don't disclose, the clinician doesn't participate, the clinician ends up giving a recommendation, and maybe the patient chooses to follow that recommendation. That is a very poor way of caring for people, particularly people with chronic conditions. So I think the responsibility is on clinicians. Make themselves smaller, establish relationships that are actually more of a partnership. Even if patients are not well educated, still try to achieve that. Provide supports during the encounter and have empathic curiosity to fully understand the patient's situation to the extent that they can. It's part of caring. You have to notice before responding. And I think doing that is difficult, but that is why medicine is difficult. And that is, I think, what clinicians should be doing to try to deal with this major distance that exists today.
Yes, I think it's very difficult for us, but it's necessary. One more question: How do you share in decision making when the patient is a kid?
Yes,
it's possible.
So I noticed that the questions are relate to difficult situations. The patient is sedated was the first one. The patient is a child is the next one. There's another question said when the patient has mental illness. And it's interesting that these questions are being asked because that suggests to me that people are comfortable having shared decision making when the patient is not a child, doesn't have mental health problems, and is not intubated. And I don't think that's true. So instead of focusing on maybe situations that may be more difficult, I think I would encourage people to focus on situations that are where shared decision making may be easy. And if it's easy, then ask yourself, why is it that it's not happening? Having said that, when you are dealing with a child, depends on the age, of course. There might be ways of for clinicians to engage the child directly in an age-appropriate way. But it's also, of course, the situation that you will usually engage the parents in making decisions, either the parents on behalf of the child or the parents and the child acting as a team. And in our countries, it's actually very common for even adult patients to make decisions with their family as a team. And so we need to become comfortable having discussions with not just with the patient, but understanding that oftentimes it is the family that will be implementing the plan of care. And so they have perhaps, maybe they don't have a final vote, but they certainly have a voice that needs to be incorporated into the discussion of the treatments that we consider. So that might be true for a child, but it also may be true for an adult that prefers to involve their family as well in making decisions. And as we discussed, it seems like it's going to be the way to go also for patients with in intensive care unit. Patients with mental health problems, that's an interesting bias, whoever asked that question, because it would suggest that you do not trust patients with mental health problems to be able to participate in decisions about their treatment. I think, except for those people who are in an acute psychotic situation where they've lost the ability to have a train of thought and that is based on reality, except for those very extreme situations, most people with mental health problems are going to be perfectly capable of understanding information and conveying their own situation, express their own wishes, and engage with clinicians in making decisions. It may take a little bit more effort, it may take some adaptations, but they're perfectly, most patients with mental health problems have not lost their ability to communicate or interact or make decisions. In fact, they're making all sorts of decisions about their life outside the consultation. So I would encourage us to not think of patients with mental health problems, except the most extreme, in terms of severity, to not think of them as completely unable or impaired in their ability to make decisions by themselves or with us. But again, we tend to, sounds like the audience is interested in looking at places where it might be difficult. I would encourage you to draw your attention to the common situations where you think it's easy and ask yourself, is it happening? And if not, why? What can we do professionally to actually make sure that we have the right conditions for doing it and to do it more regularly?
Thank you. One more, okay? It's time
Yes.
for one more?
Yes.
In your book, you say organizations must support the work of those who make care possible. How the organization can do it?
Mm-hmm.
How the organization can improve decision making?
Yes, so there are several mechanisms, and I've described it a little bit before, but it's maybe one way of thinking about it is, first, make sure that everybody in the organization understands that the reason the hospital opens its door, the reason the clinic opens its door, the reason the doctor's office opens its door is for patients to come in and to receive care. The main reason all of this exists is to care. Everything else, the business goals of the organization, are there to support the primary mission. So let's have all clarity that the main reason we work is to care for people. In many organizations, that gets lost because we are focused now on how many patients do we have to see to make sure that we make our financial targets, for instance. Well, that, converts the purpose of care, makes that, instead of the objective of what we do, makes it into the means by which we achieve our financial goals. So we just make sure that as an organization, we are clear, we're there to care. The second thing that leaders can do and managers can do, administrators can do, is to make sure that the clinicians and the patients have the right conditions for care. That means make sure that they can meet in unhurried conversations. Make sure that the rooms in which they're having conversations are not noisy. make sure that we don't interrupt the clinical encounter. The clinical encounter is sacred. And how do we create a culture by which we don't interrupt the clinical encounter with phone calls or just interrupt, nurses coming in or doctors moving around or any of that. So limit and the distractions and the interruptions, invest in walls that are thick, in doors that don't allow noise to come in, focus on the facilities and the processes within those facilities to make sure that the clinical encounter doesn't get interrupted and there is no noises that would disrupt this. If you're using electronic medical records, disable the pop-ups, disable the alerts, disable the alarms. Make sure that the medical record doesn't get all the attention of the clinician so that the clinician can notice the patient's situation and respond to it. And make sure that that organizations compensate and recognize those who spend the time, those who make themselves present and available to patients. Catch people caring. Identify people as they're caring and alert everyone else that that's the kind of behavior that you would like to see. And catch people not caring, or being cruel, and call it out as a behavior you would not want to see. Caring starts not only from the organization, caring for the people that care for the patients, but also caring for and about each other when we work in that organization. If a doctor is cruel to a secretary or to a nurse, or the nurse is cruel to a technician or to the patient and so forth, if we observe any kind of cruelty of that nature, let's call it out. For us to be able to care for patients, we need to be able to care for each other. And organizations cannot care. The only thing, and technology cannot care. Only people can care. And so we have to make sure that the people have the conditions for them to care for each other and together to care for the patients that come in seeking that care.
Do you have time for one more?
Sure.
Question?
One more.
Okay. The last one. What are the practical limits on sharing decision making? Practical limits on sharing decision making, and what are the difficulties encountered in practice?
Yeah, so the implementation of shared decision making in practice can be made hard when there's too many people scheduled to be seen, when clinicians are running late, when there are many distractions in the clinical encounter, when all the information necessary to consider the possibilities is not available, when the patients have been told not to ask questions or not to waste the time of the clinician. So a lot of the practical limits have to do with the way healthcare is organized, the way the resources are allocated, and the culture that is in place. And again, I think the focus is on those conditions of care. But those are things that can be changed. They are not unchangeable. And as a result, we need to continue to work to create the conditions for careful and kind care in which shared decision-making and patient-centered care is the easiest thing for us to do. Yeah.
Thank you. We have a wonderful moment here now, and the IBDPAC is so grateful for your presence with us, and take you to talk about sharing decision making. We hope to see you soon.
Thank you very much for having me, and good luck. Take care.
Thank you. Então, a todos que nos acompanharam aqui no YouTube essa tarde, então, nosso muito obrigada pela sua participação, e logo o vídeo estará disponível no nosso canal, falando um pouquinho aí com uma grande referência mundial sobre a tomada de decisão compartilhada. Obrigada a todos que puderam compartilhar, puderam participar. Obrigada. Tchau, tchau.